Okay, guys, so today we are going to talk about diagnostic imaging of solitary tumors of the spine. It's a very interesting article, a lot of common things that we find every day in all modalities, X-ray, MRI, CT scan. So we need to have a better understanding of what to say and how to interpret these findings. Your colleague, Dr. Mustafa, will start presenting.
Diagnostic imaging of solitary tumors of the spine. Metastatic disease, myeloma, and lymphoma are the most common malignant spinal tumors. Hemangioma is the most common benign tumors of the spine. Clinical features, clinical data, such as patient's age, symptoms, history, and laboratory finding helps make the diagnosis, the radiologic diagnosis. Margins and limits. Benign tumors usually exhibit geographic bone destruction and sclerotic margins without soft tissue extension, except for aneurysmal bone cyst, aggressive hemangioma, and eosinophilic granuloma. Conversely, malignant tumors usually exhibit poorly defined margins, permeative bone destruction, and soft tissue mass. Marrow and more particularly soft tissue edema is frequently seen adjacent to the primary bone tumor. We start with bone-forming tumors, bone island. Uh, Bone islands or inostosis are asymptomatic lesions that are discovered incidentally in patients of all ages. They are not true neoplasms and represent dense, compact bone within spongiosa. Developmental abnormality. Radiography and the CT demonstrate round osteoblastic lesions with a brush border at their periphery. Inostosis have low signal intensity at T1 and T2 MR imaging. They may show activity at bone scintigraphy in less than 10% of the cases, and most lesions remain stable. The primary alternative in the differential diagnosis is osteoblastic metastasis. Inostosis in the sacrum of 70 years old man. This the sacrum brush border.
However, you can notice here it's a non-case of prostate carcinoma. So this will be a really difficult case to distinguish whether this is osteoinostosis,
Yes.
bone island, or an osteoblastic metastasis from prostate carcinoma. You have to follow it up and correlate with the previous images whether it was there or not. Okay. However, solitary is more in favor of bone island rather than metastasis. Usually, prostate metastasis present as diffuse most common.
Osteoid osteoma. Osteoid osteoma is a benign osteoblastic lesion characterized by a nidus of osteoid tissue, often surrounded by a sclerotic reactive bone. The nidus is less than 1.5 cm in diameter by definition, with larger lesions being called osteoblastoma. The majority of the spinal osteoid osteoma are located in the neural arch. The lumbar spine is the most commonly affected, followed by the cervical, thoracic, and sacral segments. Presents with painful scoliosis. Aspirin usually provides pain relief. Scintigraphy is almost invariably positive. Dynamic gadolinium enhanced MR image can predict osteoid osteoma with greater conspicuity than can non-enhanced MR imaging. Osteoid osteoma of the lamina at T8 vertebra. 34 years. Yes.
Okay.
Yes.
Which is the lucid part.
Yes.
And followed by some mild sclerosis of the neural arch.
Yes.
This is the problem that presents as an osteoblastoma because it's the patient suffers scoliosis, but it is not a real scoliosis. It's response to pain.
Yes.
Okay. So that's why it's difficult. It needs to be treated because there's no scoliosis. Just the patient is feeling as a response to pain.
Osteoblastoma. The histologic similarities between osteoid osteoma and osteoblastoma are striking, but their clinical manifestation and natural histories differ. Osteoblastoma causes dull, localized pain, or is asymptomatic. It tends toward progression and may be locally aggressive, whereas osteoid osteoma tends toward regression. Manifest in the second and third decades of life. Osteoblastoma originate in the neural arch and often extend into the vertebral body. At bone scintigraphy, osteoblastoma demonstrate marked radionuclide uptake. Reactive sclerosis adjacent to the lesion is common at conventional radiography. The radiographic features of osteoblastoma are a lesion diameter greater than 2 cm, osseous expansion, soft tissue component, and multifocal matrix mineralization. Tumors that are mainly lytic at CT with little evidence of matrix mineralization are hypointense at T1 weighted MRI imaging and hyperintense at T2.
Osteoblastoma is just a big aggressive osteoblastoma.
Enlarge size.
The same radiologic features except contractionalness and local aggressiveness. It can have soft tissue extension.
Yes. All tumors enhance following the injection of gadolinium-based contrast material, as would be expected given the vascular nature of the lesion. Soft tissue invasion with cortical destruction must be differentiated from severe inflammatory response involving several adjacent bones and soft tissue, the so-called flare phenomena that can cause marked overestimation of the lesion size and leads to sampling error. Osteoblastoma of the sacrum, 37 years old man with sacral pain. CT shows a hypoattenuating area with central calcification and minimal surrounding sclerosis.
At the first question, you might say some lytic metastasis.
Yes.
Yes. However, the pain, the long duration, more in favor of something bigger.
Yes.
In this case, considering the size, suggest osteoblastoma. And this is what we might
Osteoblastoma, yes.
You can see
Flare phenomena by MRI.
the lesion is in one spinous process. However, the adjacent
Inflammatory process.
is flare edema. So you might, when you measure it, you might measure larger than it is. So it's overspeed of the lesion.
And with gadolinium shows marked enhancement. Yes. Another one, aggressive osteoblastoma of L5 vertebral body.
Aggressivity of
Go back.
because it appears some surrounding sclerosis. However, it's extending into the spinal canal.
Yes.
Okay, because it's spinal cord or spinal thecal sac compression. Okay, this indicates some aggressivity tumor. However, solitary, long-standing, more in favor of benign aggressive tumor.
Osteosarcoma, only 4% of all osteosarcoma involve the spine. Radiation therapy and Paget's disease are usually implicated in cases of secondary osteosarcoma in the elderly patients. In 80% of cases, CT demonstrate matrix mineralization, rarely tumors with marked mineralization originating in the vertebral body, and may manifest as an ivory vertebra, sclerosing osteoblastic osteosarcoma. And ivory vertebra not occur only in lymphoma, in osteosarcoma, metastasis. A purely lytic pattern is also seen in various subtypes, such as telangiectatic osteosarcoma. MR imaging signal intensity characteristics are usually non-specific. Fluid levels have been described in association with telangiectatic osteosarcoma, as opposite to aneurysmal bone cyst. Telangiectatic osteosarcoma with prominent fluid levels, hemorrhagic spaces, and are characterized by thick, solid nodular soft tissue surrounding the cystic space, matrix mineralization, and a more aggressive growth pattern. And you have soft tissue nodes.
This is an important thing to note. First, osteosarcoma is not always syndromic. It can present as an
Aesthetic, yes.
most of the times it's syndromic, but not necessarily always. It can present as lytic. Yani you can suggest osteosarcoma in a lytic lesion, lytic body lesion. Normally you can suggest this is my osteosarcoma.
Yes.
If they say, well, how that osteosarcoma? Okay, there are varieties that present lytic. For example, telangiectatic. Telangiectatic looks very similar to aneurysmal bone cyst.
Yes.
What's the difference? You need to look for areas of nodular
Soft tissue.
thickening and post-contrast enhancement, nodular post-contrast enhancement with more aggressive features.
In this case,
otherwise they are the same.
Yes, as in this case, CT shows permeative bone destruction and osteoid matrix. Axial T2 weighted MR imaging shows slight hypointense lesion with cystic foci. Yeah.
That's multiple system
Yes.
areas.
Axial contrast enhanced fat saturated T1 weighted MR image shows enhancement with lesions of the lesion with cystic foci. Same thing, hypointensity. Cartilage forming tumors, osteochondroma. Osteochondroma represents the most common bone tumor and is a developmental lesion rather than a true neoplasm. Osteochondroma enlarge as a result of growth at the cartilage cap, identical to a normal physical plate. After skeletal maturity, osteochondroma usually exhibit no further growth. Solitary lesions affect males more frequently than females. The average age at the diagnosis is 33 years. Osteochondroma can arise from any part of the vertebral column, but cervical spine is commonly involved with a predilection for the atlantoaxial area. Most spinal lesions occur near the tip of the spinous process or transverse process. They can also develop in the vertebral body, apical, or more rarely the articular facets. Because of overlapping of osseous structure of the spine, conventional radiography is often insufficient. CT is modality of choice for demonstrating the diagnostic appearance of marrow and cortical continuity with underlying vertebra.
Obviously, it will be very difficult to diagnose process in the spine using an X-ray.
Yes.
Of course, you need CT scan. Yes. It's not that easy. Yes. The important thing, the whole photograph is it's common for at the atlantoaxial junction. Yes. Pathologies of abnormalities or limitation of movement, anything like that, in the area of atlantoaxial joint, without trauma, for example, think of exostosis. It might happen there, it might cause severe abnormalities due to the location, its compression and limitation of movement of the joint.
At MR imaging, the lesion manifests with a peripheral rim of low signal intensity corresponding to the cortical bone and a central area of fast signal intensity corresponding to the central cancellous bone. A thin cartilage cap may be present, especially in children. With age, cartilage tends to thin and disappear at a number of points on the surface of the osteochondroma. However, a thick, more than 1 cm cartilage cap in an adult patient should raise the suspicion of an exotic chondrosarcoma. Yes.
Some sort of a bone,
Bone extending. Yes. Yes. Chondroblastoma. Chondroblastoma is a benign cartilaginous tumor with a predilection for the growth skeleton. Chicken wire calcification of the matrix is highly typical of chondroblastoma. Only 1.4% of all chondroblastoma originate in the vertebra. Most patients present during third decade of life. The tumor involves the vertebral body and posterior element. The tumor shows aggressive features at imaging with bone destruction and soft tissue mass, but no surrounding bone edema. In other cases, the CT may demonstrate a geographic lesion with sclerotic borders. Most lesions have hypointense area on T2 weighted MR image. Low signal intensity on T2 weighted MR images is associated with immature chondroid matrix, hypercellularity, calcification, and hemosiderin at histologic analysis.
So chondroblastoma has low signal T2.
Yes.
Due to all of these factors,
yes. Chondroblastoma of L3 vertebra, 23-year-old woman with a 6-month history of painful lumbar scoliosis, sagittal reformatted.
Here you can see that the vertebral body has a large critical lesion that is
Yes.
That's the first thing. The second thing interesting to notice on sagittal image, the lesion is very difficult to see. Because it's not high point, the eyes of the high point is. While we expect this tumor, this is time, we expect it to be much hyper intense. The opposite is here. So you should keep in mind that it cannot be a metastasis, unlikely to be a metastasis. Most of the other pathologies will be hyper intense one. So now we have remaining one which is chondroblastoma. Okay? And when you do contrast, you can see the contrast enhancement and the extension into the surrounding spinal.
Chondrosarcoma peak prevalence occur between 30 and 70 years of age. Men are affected 2 to 4 times more frequently than women. The thoracic and lumbar spine are most frequently affected, with the sacrum being affected only rarely. Chondrosarcoma originates in the vertebral body, 50% of the cases, posterior element 40% of the cases, or both 45%. In both vertebral body and posterior element. Chondrosarcoma of the spine usually manifests as a large calcified mass with bone destruction. Calcified matrix is detected at areas of signal void at MR imaging. The non-mineralized portion of the tumor has low attenuation on CT scan, low to intermediate signal intensity on T1 weighted MR imaging, and a very high signal intensity on T2 weighted images due to the high water content of hyaline cartilage. An enhancement pattern of the rings and arcs at gadolinium enhanced MR imaging reflects the lobulated growth pattern of this cartilaginous tumor. Extension through the intervertebral disc has been reported in 35% of the cases. Chondrosarcoma of L4 vertebral body in 41 years old man with low back pain. CT shows a large mass arising from vertebral body with cortical disruption and ring and arc calcification. Yes.
Second, chondrosarcoma is a low-grade malignancy.
Yes.
It's slowly growing.
Slowly
It takes years and years and years to grow. Okay, so this means that it will not enhance markedly. Might show some contrast enhancement, but usually it does not enhance markedly. Third, cyst is chondral lesion. It will show distinct signal characteristics on MRI of the cartilage, which is markedly hyperintense on T2, more than usual. Okay, so you can see here very hyperintense mass on the T2,
Weighted
where
MR
it
image.
is due to its cartilaginous lesion.
Cartilaginous lesion. Water content. Hematopoietic reticuloendothelial and lymphatic tumors, eosinophilic granuloma, Langerhans cell histiocytosis, previously termed histiocytosis X, include conditions that range from the usually solitary and curable eosinophilic granuloma to the disseminated process that produces Schuyler-Christian syndrome to the disseminated and rapidly fatal variety known as Lettieri-Sui syndrome disease. These three seemingly dissimilar conditions are united by a common pathologic feature. Usually occur in the children with a peak prevalence between 5 and 10 years of age. In multifocal involvement, the osseous lesion appear simultaneously or within 1 to 2 years. Vertebral involvement is seen in only 7 to 25% of the cases of Langerhans cell histiocytosis. Although almost all vertebral lesions involve collapse of the vertebral body, neurologic complications are rare and usually mild.
So this is very interesting thing. All vertebral involvement results in collapse.
Yes.
Producing there's a slide called pancake vertebra.
Yes.
But surprisingly, neurologic complications are rare. And where they happen, they are mild. Vertebral body collapse with mild, it's very interesting.
The radiographic characteristics of atypical spinal lesion consists of complete or incomplete collapse of the vertebral body, absence of an osteolytic area, preservation of the pedicellus posterior element and the adjacent disc space, absence of the adjacent paravertebral soft tissue shadow, and increased opacity in the collapsed body. In patients with typical vertebral lesion but no suspected malignancy, close observation with clinical and radiologic examination might be more appropriate than vertebral biopsy. Reconstitution of the vertebral height usually occur. Most of the remaining normal tissue of the collapsed vertebral body is the apophyseal plate, which may be damaged during biopsy, thus precluding reconstruction of the vertebral height. يعني أحسن ما تسوي biopsy.
Follow it up. It will go back to normal.
Yes.
The radiologic features, there are in fact no radiologic features, just loss of height of vertebra. That's it.
Yes.
Nothing else. Vertebra collapse. Leave it, follow it up, it will grow back, and everything will go back to normal.
12-year-old boy, radiography shows increased opacity in the
He's a
incomplete.
12-year-old boy. You don't expect vertebral body collapse in 12-year-old boy spontaneously. So most of the time it will be just an eosinophilic granuloma. There's no sufficient component, no sign of destruction, no sufficient extension, no surrounding calcium, nothing. The posterior arches preserved, pedicles preserved, everything looks good. Wait and see, it will go back to normal.
Plasmacytoma. Plasmacytoma represent focal proliferation of malignant plasma cells without diffuse bone marrow involvement. These lesions are considered to represent the early stages of multiple myeloma. The vertebral body is the most common site of involvement by the plasmacytoma due to its rich red marrow content, but the tumor frequently extends to the pedicles. Plasmacytoma usually manifests with a single collapsed vertebra. In two-thirds of the cases, the radiographic appearance is characteristic with a mixed, predominantly lytic pattern. The tumor preferentially replaces the cancellous bone, whereas the cortical bone is partly preserved or even sclerotic, resulting in a hollow vertebral body or pedicle. The cortical thickening in the arrangement of plasmacytoma appear to be unique to this tumor and results in a mini brain appearance in the axial image. In one-third of the cases, the radiographic appearance is less characteristic, with multicystic soap bubble appearance simulating a hemangioma, or perhaps a purely lytic appearance. Solitary sclerotic plasmacytoma is extremely rare and can be found in association with polyneuropathy. Like many expansile tumors involving the axial skeleton, plasmacytoma has low signal intensity on T1 weighted MR images and high signal intensity on T2 weighted images, and homogeneous marked enhancement on post-contrast T1 weighted image. In this case, a lateral radiograph shows multicystic appearing lesion involving vertebral body and neural arches at C6. Mini brain. Of mini brain, yes. As CT scan, yes. Enhancement. Extension to the spinal. Lymphoma, primary lymphoma of the brain, is a rare extranodal manifestation of non-Hodgkin lymphoma. Peak prevalence occurred in the fifth to seventh decades with a strong male predilection, 8 to 1. Spinal involvement may manifest as a paraspinal, vertebral, and epidural involvement, either in isolation or in combination. Vertebral involvement results from more frequently from the hematogenous split than from osseous invasion from adjacent lymph node. Vertebral lesions may have a sclerotic, lytic, or mixed appearance. The sclerotic ivory vertebra and mixed pattern are more common in the Hodgkin's disease. The appearance of vertebral lymphoma at CT and MR imaging is usually non-specific. Both scintigraphy shows increased radionuclide uptake in nearly all patients. Sagittal T2 weighted MR image shows a low signal intensity spinal lesion spreading over multiple levels. Okay. MR imaging shows a low signal intensity spinal lesion to the epidural. Pointer. There.
There's marked degenerative changes indicating it's an elderly patient because it's up to second decade. Because it's hematogenous spread, most of it involve multiple vertebrae. Okay? It's not really a solitary of the spine. If you notice here, these are just modic changes, okay, with loss of height here and there. However, here there is suddenly loss of signal. You can see this area. There is loss of signal with a prevertebral soft tissue component and intradural soft tissue component. However, it's not crossing the intervertebral disc. The intervertebral disc appears preserved, okay? And after contrast enhancement administration, you can see there is contrast enhancement in the soft tissue component here and here, less marked in the vertebral involvement. Okay, so this is the lymphoma, and most of the times, in fact, almost 100% of patients will have previously known lymphoma. They know that he has a lymphoma, just the new vertebral
Ewing sarcoma, although the vertebral column is frequently involved in pre-terminal metastatic Ewing sarcoma. Primary vertebral Ewing sarcoma is quite rare. Primary vertebral Ewing sarcoma is usually seen in the second decade of life with a slight male predilection. The sacrum is the most frequently involved site, followed by the lumbar spine. In the non-sacral spine, the majority, 60% of the cases, originate in the posterior element with extension to the vertebral body. The ala is the most frequently affected sacral site. The disc space are usually preserved. Lesions may be lytic, sclerotic, or mixed with associated vertebral compression. Nearly all tumors, 93%, are lytic and morphologically aggressive. A purely sclerotic pattern is rare and might correspond to the necrotic and reactive bone formation. Other unusual imaging findings include vertebra plana, ivory vertebra, and pseudohemangioma. Invasion of the spinal canal is common, 91% of the cases, often with a large mass. The paraspinal component is often larger than the intraosseous lesion. Paraspinal.
Whatever, in the spine, in the bone, in the joint, anywhere. When there's ewing sarcoma, or at least suspected ewing sarcoma, there is a huge soft tissue component. Till now, I have not ever seen a ewing sarcoma with small soft tissue or gross soft tissue. There's always big soft tissues.
Vertebral hemangioma. Vertebral hemangioma is considered to be a lesion of bone, usually of dysembryogenic origin or a hamartomatous lesion. Spinal hemangiomas are common and frequently multiple. The prevalence of hemangioma seems to increase with age and is greatest after middle age, with a slight female predilection. Most seen in the thoracic and lumbar spine. Hemangiomas are they are usually confined to the vertebral body, although they may occasionally extend to the posterior element. Most spinal hemangioma are asymptomatic. Occasionally, vertebral hemangioma may increase in size and compress the spinal cord and nerve roots. Compressive vertebral hemangioma can occur in patients of any age, with a peak prevalence in young adults and preferentially occur in the thoracic spine. Hemangioma in the vertebra cause rarefaction. Hemangioma in the vertebra cause rarefaction with exaggerated vertical striation or a coarse honeycomb appearance. CT shows the pattern as a multiple dots, polka dot appearance representing cross-section of the reinforced trabeculae. At scintigraphy, the appearance of osseous hemangioma range from photopenia to moderate increase in the radiotracer uptake. The presence of high signal intensity on T1 and T2 weighted MR images is related to the amount of adipocyte or vessels and interstitial edema respectively. Fatty vertebral hemangioma may present inactive forms of this lesion, whereas low signal intensity at MR imaging may indicate a more active lesion with a potential to compress the spinal cord. The radiographic and the CT appearance of compressive vertebral hemangioma can be misleading with irregular trabeculae and lytic areas, poorly defined expanded cortex and soft tissue expansion.
There is an increase
Yes, sir.
they call the cortical appearance. And you can see on the external images, these are the polka dot side. From vertical trabeculae to all the way to the because there is some lytic process there. Okay? Sometimes the tumor can be aggressive. Extend to the soft tissue, spinal canal, sort of malignant, but it's not malignant. It's a aggressive mode. Okay? So this is usually treated with embolization because it's vascular one needs kind of infection.
Here, extraosseous extension. Chordoma is a rare malignant neoplasm arising from the remnant of the primitive notochord. Chordoma generally occur in late middle age, with a peak prevalence in the 5th and 6th decade of life. Spinal chordoma have a 2 to 1 male to female ratio. Chordomas most commonly arise in the sacrococcygeal region, 50% of the cases, followed by the spheno-occipital region, 35%, and vertebral bodies, 15%. Sacrococcygeal tumors usually start in the lower sacrum and coccyx. Spinal chordoma arise more frequently in the cervical spine than in the thoracic and lumbar regions. The most common site of involvement in the mobile spine is the vertebral body with sparing of the posterior element. Clinical manifestation is often subtle because chordomas are low, slow-growing lesions. The most aggressive manifestation is a destructive lesion of a vertebral body associated with a soft tissue mass with a collar bottom or mushroom appearance and a dumbbell shape, spanning cervical segments and sparing the discs. Segments, yes.
So vertebral abnormal normal disc, abnormal vertebral normal disc, abnormal vertebral multiple vertebral normal disc.
Areas of amorphous calcification are noted in 40% of chordomas of the mobile spine and in up to 90% of sacrococcygeal lesions.
Most of the features are similar to the they look almost the same, except the location is more common in the sacrum and the spheno-occipital area, while chordomas are in the vertebrae.
Most chordomas are iso or hypointense relative to the muscle on T1 weighted MR image. The focal areas of hemorrhage and high protein content of the myxoid and mucinous collection that may be seen in the chordomas account for the high signal intensity in T1 weighted images. On T2 weighted images, most chordomas have high signal intensity that reflects their high water content. After the injection of the gadolinium-based contrast material, most tumors demonstrate moderate heterogeneous enhancement, but ring and arc enhancement and peripheral enhancement have also been described. Sacrococcygeal chordoma in yes. Yes.
You have to do differential diagnosis. It's still not a chondrosarcoma. So you do differential. Both of them are low grade malignancy. Both of them are they are early age. Both of them are not very aggressive lesions, let's say. You can see the
mushroom
or bottom or dumbbell shape. So both the vertebra, bulging into the spinal column, compressing the spinal cord, and at the same time, if you notice, the vertebral discs are completely normal. It's not involving the vertebral disc at all.
Aneurysmal bone cyst is a benign bone lesion of unknown origin. It is a relatively rare lesion that represents 1.4 to 2.3 of the primary bone tumors. The spine is involved in 3 to 20% of the cases. At histologic analysis, aneurysmal bone cyst is typically characterized by blood-filled cystic spaces separated by spindle cell stroma with osteoclast-like gain cells and osteoid or bone production. The three main hypotheses reported in the literature purpose that the lesion is the result of either the improper repair of the traumatic subperiosteal hemorrhage, a vascular disturbance of the bone, or hemorrhage into the pre-existing lesion.
Either it's hemorrhage into the bone, or that's improper repair, or there was a pre-existing lesion that would
in 29 to 35% of the cases, a pre-existing lesion can be identified. Common precursor lesions include osteoblastoma, angioma, and chondroblastoma. Aneurysmal bone cysts usually occur between the ages of 5 and 20 years, but can manifest at any age. There may be a slight female predilection. Spinal involvement is typically in the posterior element, although extension into the vertebral body is common. Spinal aneurysmal bone cysts may extend into the adjacent vertebra or intervertebral disc, the ribs, and the paravertebral soft tissue. The natural history of aneurysmal bones is evolving through four radiologic stages: initial active stabilization and healing. Initial active stabilization and healing. In the initial phase, the lesion is characterized by a well-defined area of osteolysis. This is followed by the growth phase, in which the lesion has a purely lytic pattern and sometimes ill-defined margin. Later, during the stabilization phase, the characteristic soap bubble appearance develop as a result of maturation of the bony shell. CT and MR imaging typically show a well-defined lesion with internal septation. The presence of a solid component with diffuse contrast enhancement should raise suspicion of secondary aneurysmal bone cyst. Although it might be encountered in the solid variant of aneurysmal bone cyst, the prominent bone scintigraphy. The predominant bone scintigraphic pattern in aneurysmal bone cyst is moderate to intense radiotracer accumulation in the periphery of the lesion with little activity at its center. Donut sign. A finding that is evident in about 64% of the cases. However, this scintigraphic pattern lacks specificity, since it is also found in the gain cell tumor, chondrosarcoma, and telangiectatic osteosarcoma. Here. Enhance it. There is no soft tissue component. There is no mass or nodules. Just that are enhanced. Indicating most likely will be an ABC. Okay. So soft tissue component for pre-existing lesion, because you might need to treat the pre-existing lesion rather than the ABC itself. Gain cell tumor is a composite of sheets of stromal ovoid mononuclear cells with uniformly distributed osteoblast gain cells. This tumor occurs in skeletally mature patients in the second to fourth decades of life, more frequently in the females. 7% of gain cell tumors occur in the spine. The sacrum is affected in 90% of such cases. The tumor is usually located in the upper sacrum and frequently lateralized in the sacral wing. Extension into the iliac wing through the sacroiliac joint is possible. The tumor usually predominates in the vertebral body with frequent involvement of the posterior arch. The tumor is limited to the vertebral body and the pedicle in only 21% of the cases. Extraosseous involvement of the soft tissue is seen in 79% of the cases. Intervertebral disc invasion and extension into an adjacent vertebra is possible. The vertebral disc more likely to invade the disc than other tumors. Even metastasis are likely to invade the disc. Radiography typically shows a lytic lesion with cortical expansion. A purely osteolytic pattern is also possible. CT demonstrates absence of mineralization and lack of sclerotic rim at the margins of the tumor. Bone scintigraphy shows increased radiotracer uptake in all patients. The tumor usually has low to intermediate signal intensity on T1 weighted MR image. Areas of high signal intensity can suggest relatively recent hemorrhage. More specifically, most gain cell tumors of the spine have low to intermediate signal intensity on T2 weighted images. This appearance seems to be caused by hemosiderin deposition and high collagen content. More specifically, most gain tumors of the spine have low to intermediate signal intensity on T2 weighted image. This appearance هاي إعادة دكتور. Yes. And a peripheral low signal intensity pseudocapsule may also be seen. Yes. Sagittal, yes. Yes. Fibrous dysplasia is a benign fibro-osseous lesion characterized by irregularly shaped trabeculae of woven bone and a fibrous component composed of cytologically blunt spindle cells. It occurs in both children and adults and has an equal gender distribution. Vertebral involvement is rare but occurs more frequently with polyostotic disease. The lesion is frequently asymptomatic, but pain and fractures may be part of the clinical spectrum. Radiography and CT usually show a mildly expansile lesion with a blown-out cortical shell or a lytic lesion with a sclerotic rim. Ground glass matrix is common and characteristic. Lesions may also contain islands of cartilage. Fibrous dysplasia has variable MR imaging characteristics, typically intermediate to low signal intensity on T1 weighted MR and variable signal intensity on T2 weighted images. Fibrous dysplasia shows a mild to marked increase in radionuclide uptake at bone scintigraphy. CT scan shows mild expansile lytic lesion with a sclerotic rim involving the vertebral body and neural arch. This ground glass. Initial diagnosis of primary spinal tumors, metastatic disease. Metastases are the most common vertebral tumors. Osteolytic metastases occur more frequently than the osteoblastic metastases. Some metastases have a mixed pattern with areas of osteolysis and areas of sclerosis. Typically, metastases are multiple and variable in size with cortical disruption, osteolytic lesions. Vertebral compression fracture and epidural tumor are common in metastases. Some slow-growing metastases may mimic a primary bone tumor with a mineralization and sclerotic margins. Paget's disease is a chronic metabolic disorder of abnormal bone remodeling in the adult skeleton. It is rare in patients less than 40 years old. In the spine, the vertebra is expanded. The typical picture frame vertebra shows a coarse and sclerotic peripheral trabecular pattern and central osteopenia. Other patterns of Pagetic vertebra include ivory vertebra and isolated posterior arch involvement. The Pagetic bone marrow ivory vertebra, yes. Posterior arch. The Pagetic bone marrow contains fatty areas with a heterogeneous distribution. Bone scintigraphy demonstrates the extent of Paget's disease. Sarcomatous transformation of the lesion is rare, less than 1% of cases. Osteosarcoma? Yes. Granulomatous spondylitis in spinal tuberculosis. In spinal tuberculosis, concomitant pulmonary tuberculosis occur in approximately 10% of cases. MR imaging typically shows rounded, well-limited abscess surrounded by the bone marrow edema with a normal disc space. Yes. Large paraspinal abscesses are frequently associated. Brucellosis is frequently associated with bilateral sacroiliitis. Echinococcal infection. Hydatid cysts cause multiseptated lesions with minimal enhancement. Cyst rupture may cause anaphylaxis. A specific blood test is useful in making the diagnosis. Sappho syndrome, synovitis, acne, osteolysis, hyperostosis, and osteitis. Syndrome occur in young and middle-aged adult in association with rheumatologic and cutaneous lesions. Seronegative spondyloarthropathy. Bone scintigraphy is very sensitive and often reveals asymptomatic skeletal lesions associated with various typical sites of involvement. The dominant radiographic feature is sclerosis in combination with a variable amount of osteolysis and periosteitis. Hyperostosis is seen in long-standing disease. Both the multiplicity and location of the corner lesion may be useful clue to the diagnosis. Brown tumor. A classic manifestation of hyperparathyroidism can arise in the spine, causing neurologic compromise related to both collapse of osteolytic vertebral lesion and tumor growth within the spinal canal. Schmorl's nodes represent vertical disc prolapse through the areas of weakness in the vertebral end plate. Schmorl's nodes are often multiple and occur predominantly in the thoracolumbar spine. Recently formed Schmorl's nodes can be painful and may be indistinguishable from inflammatory or tumoral disease in terms of signal intensity. The identification of end plate defects or intranuclear cleft bending the disc at either CT or MR imaging is helpful in making the correct diagnosis of acute Schmorl's nodes. Schwannoma are usually isolated lesions except when they are associated with neurofibromatosis type 2. They arise from the nerve sheath and large tumors may be mistaken for spinal tumors. Radiography, CT, and MR imaging may show widening of the affected foramen.
Comments?